Ladies and gentlemen, I'm Antonio Bacelar, co-editor from Cardiosource in Português, and I have the pleasure to be joined by Dr. William Boden, who is a professor of medicine at the University of Buffalo and who just presented the AIM-HI trial, a trial that evaluated the extended release niacin in patients with cardiovascular disease, and the question that if this addition would further reduce the cardiovascular events in patients already taking statin and with the LDL on goal. Dr. Boden, thank you for being with us. Please, could you summarize the background of the study and some comments about the study design?
Sure. So thank you, Antonio. Well, first of all, we know that even in patients who achieve optimal levels of LDL reduction down to, let's say, the low 60s, continue to experience increased events. So LDL reduction therapy alone doesn't mitigate the residual risk that occurs in patients who achieve even very desirable levels of LDL. And one of the candidate variables for residual risk has been low levels of HDL. We know that there's an inverse relationship between HDL and cardiovascular events, both for men and women. So the lower the HDL, the higher the risk for developing coronary heart disease, death, or stroke. So AIM-HI was a study that was designed to really test the hypothesis that the combination of extended release niacin given in a high dose of 1,500 to 2,000 milligrams per day when added to simvastatin, 40 milligrams to 80 milligrams per day, would be superior to placebo plus simvastatin in reducing a combined primary endpoint of coronary heart disease, death, MI, stroke, hospitalization for acute coronary syndrome, and symptom-driven revascularization. This was to have been a 2.5 to 7 year trial with an average 4.6 year follow-up. But what occurred is that in late April, when the Data Safety and Monitoring Board met to review the findings of the study, they showed that the two treatment arms were virtually identical with respect to the primary endpoint. And furthermore, they observed that there was an unexpected increase in the occurrence of ischemic stroke in the patients who had been assigned to niacin, and that at the time was a borderline statistical significance. So those two factors led the Data Safety and Monitoring Board to recommend to the NHLBI to stop the study approximately 18 months earlier than planned. So we had a mean 36-month follow-up. And then the bottom line is that 94% of these patients had been receiving a statin at the time of entry. 75% of them had been taking a statin for as long as a year, and 40% for 5 or more years. And they had a very low level of LDL at baseline. It was 71 milligrams per deciliter at baseline. So we were starting out with a low LDL, and we were starting out with a low HDL of 34. So in spite of that, what we did observe is that niacin increased HDL by 25%, from 34 milligrams per deciliter to 42. It decreased triglycerides by almost 30%, from 164 down to 120. And it decreased LDL by an additional 16%. So despite those very favorable changes in HDL, triglycerides, and LDL, this did not translate into a measurable clinical benefit in this group of patients. So I think what we can conclude is that if you are a stable, non-acute patient with cardiovascular disease, as we included in the trial, and if you can achieve and maintain a very low level of LDL cholesterol on a statin, the study provides no evidence to support the administration of niacin to further reduce clinical events.
And in your opinion, why do you think we had some negative results? Do you think that was a underpowered study, or maybe the maximum we can achieve is like the goal of LDL? Like, is the HDL just a marker of risk?
Well, we know that HDL is in fact an important marker of risk. But I don't believe this is a study that was underpowered. I mean, the 95% confidence interval, the lower boundary, excludes or rules out as little as a 13% benefit. So in order to, let's say, model or design a study like this to show maybe a 10% benefit, you'd need 28,000 patients. And the point is that if all you saw was a 10% difference, would it matter clinically? So I would say probably not. I mean, there was absolutely no difference between the two groups. And so I think we did answer a very important question. The important question they answered is, in patients who have achieved such low levels of LDL, do we need to worry about HDL in terms of residual risk and treating it? And I think we answered that question in this trial. The answer is no.
And what do you think that account for the increment of high raise of LDL in the placebo group?
You mean HDL? In the
HDL, sorry.
HDL. That was an unexpected finding. I mean, we had again, we started out with a range of 34 to 35 at baseline, and there was about a 3 milligram per deciliter increase in the HDL in placebo-treated patients. It's not clear why that occurred. It's possible that we know that simvastatin, for example, which was used in the study, is a drug that has the ability to raise HDL. And there were more patients, 25% of the patients in the simvastatin group were taking the 80 milligram dose, as compared with only 18% in the combination therapy group. So it's possible that the higher dose of simvastatin in the simvastatin monotherapy arm only could have resulted in an increase in HDL sufficient to make the difference between the two groups less significant.
And one last question. Based on these results, would you change your clinical practice about the use of extended release niacin?
So my response to that is, what is the percentage of patients in a real-world clinical practice who can actually achieve the levels of LDL reduction that we did? Only about 15 to 20% of patients. So I would say that if you're among the 15 or 20% of patients with cardiovascular disease who can get the LDL down into the low 60s, then I think we can conclude from the AIM-HIGH trial that there's no need to treat that patient with niacin. What we don't know is whether patients with much higher levels of LDL or patients who are higher risk, such as the MI patient and the ACS patient, might have a differential outcome or a different result with niacin. And so we have to wait further study.
Dr. Boden, thanks for your excellent presentation.
Thank you.
And we appreciate your time for talking to the Brazilian Society of Cardiology. Thank you.
My pleasure, Antonio. Thank you so much for the opportunity.